we go. All right, guys, trauma, it applies to fundamental knowledge to provide basic and selected advanced emergency care and transportation based on an assessment finding for acutely injured patients. Let me close that out. All right. Bleeding, the pathophysiology, assessment and management of bleeding and fluid resuscitation. These, you will basically be, this is your competency, your assessment and your management of being able to stop the bleed and essentially save your patient's life. The pathophysiology applies to comprehensive knowledge of the pathophysiology of respiration and perfusion to patient assessment and management. Bleeding can be one of the most time-sensitive conditions. It can be external and obvious or internal and hidden. Second most common cause of shock. I had a note here. It says it's the second most common cause of shock. When you're bleeding out and you're losing a lot of blood, what type of shock is that? You guys remember that? You can throw it in the chat.
There's 20 people in here. Somebody's going to have to answer.
There we go. Okay. So with that being said, I'm just going to throw another iron in the fire here real quick before we move on. With hypovolemic being the second most common cause of shock. Anybody know what your first one is? What type of shock is your most common cause? Anybody? Except the good guess. Good guess. Distributive is your answer there. Septic is a very good answer because, yeah, it just, that's a very good answer. But anyway, the hypovolemia can cause weakness, shock, or death. So bleeding can be one of the most time-sensitive conditions you will face as an advanced medical technician. Bleeding can be external and obvious, or it can be internal or hidden. And like we said, it is the most common, second most common cause of shock. Perfusion is the circulation of blood within an organ or tissue in adequate amounts to meet the cell's current needs for oxygen, nutrients, and waste removal. Blood enters an organ or tissue through the arteries, then the arterioles, and finally the capillary beds. While passing through the capillaries, the blood delivers nutrients and oxygen to the surrounding cells and picks up the waste that has been generated. Oxygen and carbon dioxide exchange takes place in the lungs. The autonomic nervous system monitors the body's needs and adjusts the blood flow as required. In shock, which is hypoperfusion, the system fails to provide sufficient circulation for every body part to perform its function. Emergency medical care is designed to support the heart, which is the cardiovascular system, the brain and spinal cord, central nervous system, the lungs, your respiratory system, and the kidneys, which is your renal system. Okay. The cardiac cycle is a repetitive pumping process that begins with the onset of cardiac muscle contraction and ends with the beginning of the next contraction. Preload is the amount of blood that is returned to the heart to be pumped out. Afterload is the pressure in the aorta or the peripheral vascular resistance, which is known as PVR, against the left ventricle that must pump blood. The cardiac cycle is connected to bleeding and shock through its relationship with blood pressure equals cardiac output, peripheral vascular resistance. Your MAP equals your diastolic pressure, which is multiplied by 1/3 of your pulse pressure. Just as a little side note, guys, you will see that again. That's very important. So make sure you put a star by that, asterisk that. You'll see that on some tests coming up. Pulse pressure is calculated by subtracting the diastolic blood pressure from the systolic blood pressure. Cardiac output is the amount of blood pumped through the circulatory system in 1 minute. The delivery of oxygen to the tissues is dependent on an adequate heart rate, stroke volume, hemoglobin levels, and arterial oxygen saturation. Just to reiterate, guys, that entire slide right there, those formulas, knowing how to calculate that, you will need to know that in the future. A hemorrhage is your discharge of blood from the blood vessels. It also just simply means bleeding. Bleeding can range from a nicked capillary to a severely spurting artery to a ruptured spleen. External bleeding can be controlled by using even pressure dressings and or splints, hemostatic dressings, tourniquets, or a pressure bandage. Rely on signs and symptoms to determine the extent and severity of the bleeding. So just to reiterate, I know that in our skills day locally, we talked about how fast it takes you to lose consciousness if you have an arterial bleed. Does anybody know how long that takes? If, how long you have to put a tourniquet on before you go unconscious? Any guesses? All right, I see a couple. Chris, you want to throw that out there? Guys, think lower than what y'all are already guessing.
So just don't forget about your tourniquets. I know everybody preaches that's the last resort, but at the same time is if you feel that is needed for this particular patient, then do it. It's okay. If there's some of those arterial bleeds or it's one of those you're like, nobody's going to tell you no. She's on point, but just make sure that you use those tourniquets. You put them high and tight. They're wonderful tools. I've used them multiple times in my career, and it's one of those, just do it. We're going to pull a Nike out on y'all.
All right, to answer the question, it's way lower than a lot of you are putting. Jeremy, you got the closest. It's about 19 seconds and then you lose consciousness. It happens fast, guys. If the tourniquet does not work, you can always just add on another pressure dressing. You can continue to put direct pressure, do whatever it takes to stop that bleed. Just because you have one thing that's taking care of the bleed, you can use all your tools in your toolbox. You don't have to just use one. Keep that in mind. External hemorrhaging is usually the result of a break in the skin. Its extent or severity is often a function of the type of wound and the types of blood vessels that have been injured. Blood from an open vein is much darker and flows steadily. Bleeding from damaged capillary vessels is dark red and oozes from a wound steadily but slowly. These descriptions are not infallible, which means, again, guys, it could look different from person to person. Use your judgment, use your textbook knowledge, and all your skills that you've been given. Some injuries that you might expect to be accompanied by considerable external bleeding do not always have serious hemorrhaging. All right, internal hemorrhaging. Internal bleeding as a result of trauma may appear in any portion of the body. Non-traumatic internal hemorrhage often occurs in cases of GI bleeding from the upper or lower GI tract, ruptured ectopic pregnancies, ruptured aneurysms, or other conditions. Your mechanism of injury, we all know that's a big term for trauma, so keep that in mind when it comes to your trauma patients. A high energy mechanism of injury should increase your index of suspicion for the possibility of serious or unseen injuries. Internal bleeding commonly occurs as a result of falls, blast injuries, automobile or motorcycle crashes. Look for signs of injury using your DCAP BTLS over the chest or abdomen, including contusions, abrasions, lacerations, and other signs of injury or deformity. I know that in last class we went over DCAP BTLS. Just curious, anybody that can, I'm big on interaction and just recall for you guys. If somebody can throw that in the chat what DCAP BTLS stands for, that would be really cool. Maybe even some bonus points. I don't know. Maybe not, but just that would be really cool if somebody could throw that in there just to help everybody remind what that is. Place, guys, hang on. All right, so your nature of illness for internal bleeding. Internal bleeding is not always caused by trauma. Common causes of non-traumatic internal bleeding include bleeding ulcers, bleeding from the colon, ruptured ectopic pregnancy, and aneurysms. In older patients, dizziness, faintness, or weakness may be the first sign of non-traumatic internal bleeding. Going back up here, talking about the mechanism of injury real fast. Back when, probably about a year or so ago, I ran a call that it was down one of our major highways, and it was MVC versus tree. And when I say that it's really important to use your mechanism of your suspicion, index of suspicion and mechanism of injury, that's huge, guys, because when we flew in and landed, you could tell that the steering wheel and everything was completely sheared off. There was nothing left of the front of the truck. The steering wheel was sheared off. The guy was actually really lucky to be alive, but long story short, there was a lot of internal injuries that we would have never seen that he had, but due to the index of suspicion and just knowing the types of injuries that come from these types of crashes really helped us be able to treat this patient. So that is a big deal. And I'm going back to the chat real quick. So good job at throwing that in the chat there. That's something that's not going to go away. So I just want you guys to keep going over it. Signs and symptoms of internal bleeding is pain, swelling in the area of the bleeding, bruising, bleeding into the chest, and it may cause dyspnea, in addition to tachycardia and hypotension. Hematoma, mass of blood in the soft tissues beneath the skin. Other signs and symptoms: hematemesis, melena, hematochezia, pain, tenderness, bruising, guarding, or swelling, broken ribs, bruises over the lower part of the chest, or a rigid, distended abdomen. The first sign of hypovolemic shock, hypoperfusion, is generally a change in mental status, such as anxiety, restlessness, or combativeness. Signs in hypoperfusion suggesting internal bleeding. Again, at your altered level of consciousness, they're gonna tank fast. They're gonna go down fast. Tachycardia, weakness, fainting, and dizziness at rest. Thirst, nausea, vomiting. Cold or moist type, clammy type skin. Shallow, rapid breathing. Dull eyes. Slightly dilated pupils that are slow to respond to light. Capillary refill or of more than 2 seconds in infants and children, and a weak, rapid, thready pulse, and decreasing blood pressure, which is a very late sign. They will start to, let's see, hang on, I'm trying to see what you're saying. That's okay, I've got notes over here I'm reading as well. So the main part that I want you guys to see is on the slide. I do have notes here that I am adding in. It's just, that's not the biggest thing. It's just little side notes in there, okay? But just remember that your decreasing blood pressure is a very late sign. All right, the importance of bleeding. If the typical adult loses more than approximately 2 pints, which is 1 liter of blood, substantial changes in the vital signs occur. The heart rate and respiratory rate will increase and the blood pressure decreases. The same effect is seen with the smaller amounts of the blood loss in infants and children. Hemorrhagic shock is a condition in which low blood volume results in inadequate perfusion and even death. Consider bleeding to be serious if there is a significant mechanism of injury, especially when the mechanism of injury suggests that a severe force affected the abdomen, chest, or both. If the patient has a poor general appearance, and if there are signs and symptoms of shock, hypoperfusion that are evident, substantial amount of blood loss, rapid blood loss, or uncontrollable bleeding. Its own, bleeding tends to stop rather quickly in response to internal clotting mechanisms and exposure to air. When vessels are lacerated, the open ends of the vessel begin to narrow and vasoconstrict. Hemostasis, which means the platelets aggregate at the injured site, plugging the hole and sealing the injured portions of the vessel. A number of medications, including anticoagulants, interfere with normal clotting. Sorry, guys. Beta blockers can also cause vasoconstriction. There is a table in your book, table 27.1, that shows the classes of the hemorrhaging. I would take a look at that. That's pretty significant, not necessarily for test purposes, but whenever you're providing patient care, that helps you determine how aggressively to treat your patient and then how to even talk to the doctors once you get to the hospital about how much blood loss was at scene or whatnot. A patient with hemophilia should be transported immediately. The trauma triad of death, which is your acidosis. I see it's fixing to talk about it down here, but I'll just keep going in that case. A combination of hypothermia, coagulopathy, and acidosis that substantially increase mortality in trauma patients. All in simple terms, guys, keep your patients warm, keep the bleeding under control, and if you can do those two things, the other things will follow. There's not much you can do for the acidosis initially other than keeping them warm and doing what you need to do to stop the bleeding. The acidosis is another topic for later. Just work on their breathing, put an end title on your patients. Coagulopathy, the disruption of the blood's ability to clot. The disruption of the body's ability to clot can result in further hemorrhage, leading to increasing hypoperfusion. Identify the conditions of hypothermia, coagulopathy, and acidosis in the setting of trauma and intervene where possible. Hypothermia in the trauma triad of death refers to the body's inability to maintain normal operating temperature. Your patient assessment is your scene size up. The assessment of any patient begins with a thorough scene size up and proceeds to your general impression in your primary survey. After the scene is safe, take the appropriate standard precautions. Your gloves, your mask, eye shield, and gown. Blood will look different on different surfaces. Attempt to determine the amount of external blood loss. Determine the nature of illness or the mechanism of injury. Consider the need for additional resources such as advanced life support unit. Primary survey. Substantial bleeding, internal or external, is an immediate life threat. Primary survey of the patient includes a search for life-threatening bleeding. Be aware of obvious signs of injury and distress, such as facial grimace. Perform a rapid full body scan of the patient. Follow the XABCDE mnemonic for trauma, assessing for the managing exsanguinating hemorrhages. When life-threatening external bleeding is seen, begin the treatment of shock. Don't wait till it's too late. These patients you want to treat aggressively. Do not become sidetracked by applying dressings and bandages to a patient who has more serious problems. Determine the patient's level of consciousness upon the APU scale. After addressing life-threatening bleeding, next manage immediate threats to life involving the airway and breathing. You must be able to quickly assess pulse rate and quality, determine the skin condition and color, and the temperature, and check the capillary refill time. Any internal bleeding must be treated promptly. Pay close attention to the patient reports of pain or tenderness, development or tachycardia and pallor. When making a transport decision in cases of hemorrhaging, determine how fast the transport decision should be made and where the patient should be taken to for definitive care. Take into consideration factors such as the need for stitches, whether the patient has had a tetanus shot in the last 10 years, whether the patient or his or her companion is reliable and will follow up properly. Also consider the availability of a regional trauma center. Your history taking. Investigate the chief complaint and be alert for signs and symptoms of other injuries due to the mechanism of injury and or your nature of illness. Carefully assess the mechanism of injury in trauma patients. The next table in your book, table 27.2, lists some mechanisms of injuries that can give clues about internal bleeding. With substantial trauma, assess the entire patient, looking for the source of the problem, any pre-existing illnesses, and other issues. Gather information on the patient's chief complaint using the OPQRST mnemonic and obtain a sample history. Your secondary assessment. A detailed, comprehensive examination of the patient to uncover injuries or illness that may have been missed during the primary survey. Record vital signs, complete a focused assessment on pain, and attach appropriate monitoring devices. Assess the respiratory system, assess the airway for the patency, and determine the rate and quality of respirations. Look for distended neck veins and a deviated trachea. Check for paradoxical movement of the chest wall and bilateral breath sounds. Assess the cardiovascular system specifically and the rate and quality of the pulses. Assess the neurological system to formulate baseline data to guide further decisions. Assess the musculoskeletal system, obtain baseline vital signs to observe the changes that might occur during treatment. Most of these patients, I think it was Chris' lecture on Monday, we were talking about the monitors and how they're set for every 5 minutes. These patients should be set every 2 to 5 minutes, depending on severity. They don't need to be any longer than that because they're going to tank. And you want to see the trends downward as soon as you can see them. Let's see. In geriatric patients, the pulse rate may not increase with early shock. Try to determine the patient's normal baseline blood pressure and circulatory status. Use monitoring devices to quantify oxygenation and circulatory status. The reassessment. Constantly reassess your patient, especially in the areas that showed abnormal findings during the primary survey. Sorry, guys, my allergies are killing me. Assess the effectiveness of any interventions, especially tourniquets and treatments provided to the patient. That means once you put your tourniquet on, it's not one and done. It doesn't mean that it's constantly, that it's good. You need to constantly get back on that and check that. Again, if for some reason your patient didn't have a pulse in their arm when you initially put that tourniquet on, but they have a pulse now and they're starting to lose more blood, then obviously there's been a change in the tourniquet security. In all cases of severe bleeding, obtain the patient's vital signs every 5 minutes en route to the ED. It is important to recognize, estimate, and report the amount of blood loss. With internal bleeding, describe the mechanism of injury or nature of illness and the signs and symptoms that make you think that internal bleeding is occurring. Your external hemorrhaging, it can be managed with direct pressure, combined with pressure dressings and or splints or tourniquet. You need that. Arterial bleeding may take 5 or more minutes of the direct pressure to form a clot. Pressure stops the flow of blood and permits normal coagulation to occur. The use of a tourniquet is preferred for external bleeding in an extremity that cannot be controlled with the direct pressure and a pressure dressing. Provide high flow oxygen and assist ventilation if needed, with attention to cervical spine control in the trauma patients. To control external bleeding, follow the steps that you see in the table in skill drill 27.1. Apply bulky dressing to stabilize any object protruding from the wound and apply pressure as best as you can without interrupting until bleeding is controlled. That being said, if you put a pressure dressing down on a wound, say my arm's bleeding, I'm trying to put it in the screen here so everybody can see it. Say my arm's bleeding and you put a pressure dressing down, don't take anything off of this arm that you've already got. You just layer it on top and you just keep putting those dressings on top of each other, because if you try to peel that back and peel that off, you're going to disrupt that clotting process and it's going to start bleeding all over again. Okay. Never remove an impaled object from a wound unless it is through the cheek and it interferes with the airway, or in the chest if it interferes with chest compressions. Create a pressure dressing to maintain the pressure by firmly wrapping a sterile, self-adhering roller bandage around the entire wound. If direct pressure fails to immediately stop the hemorrhaging, apply a tourniquet to the groin or the axilla above the site of the bleeding. All right, more about tourniquets. It is useful if it is useful if a patient has severe hemorrhaging from an extremity injury below the axilla or groin, and when the other methods are ineffective. A number of commercially available tourniquets are marketed. You have your cat tourniquet, and then you have your soft T, and then you see all those that are listed. The ones that you're going to be mainly using are the cat tourniquets. And it looks like the skill drill 27.2 lists the steps for applying the commercial tourniquet. All right, this figure shows commercially available tourniquets: the combat application tourniquet, the special operations forces tactical tourniquet, your ratcheting medical tourniquet, your stretch wrap and tuck tourniquet. Basically, just one rule of thumb: if these things, basically you want it in the actual packaging, say your cat that it came in, you want it to not ever have been used even for practice, because you want that to be as tight as it possibly can. So if it is open and has been used, don't try to use that on a patient. You want it as tight as possible. Let's see. A tourniquet is typically released at the hospital. If a commercial tourniquet is not available, apply a tourniquet using a triangular bandage and a stick or rod. Whenever applying a tourniquet, ensure the tourniquet is proximal to the zone of injury and as close to the groin or axilla as possible. Use the widest bandage possible. Never use a wire, a rope, or a belt, or any other narrow material. Make sure the tourniquet is tightened securely. Never cover a tourniquet with a bandage. Inform the hospital both in your radio report and your verbal report on arrival at the ED that the tourniquet has been applied, and do not loosen that tourniquet after you have applied it. Splints. Air splints can control the bleeding associated with severe soft tissue injuries. It acts as a pressure dressing applied to an entire extremity rather than to a small local area. Rigid splints can help stabilize fractures as well as reduce pain and prevent further damage to soft tissue injuries. Traction splints are designed to stabilize isolated femur fractures, and after application, monitor circulation in the distal extremity. Hemostatic agents work by causing enhanced clot formation in the wound site. That's your quick clot. I don't know how many services actually have that. When I was on the truck, they had it and then they didn't have it. And then whenever I was on the aircraft, we had it. But I think it's dependent on what service you're with and what they order. The agent adheres to the damaged tissue and either dehydrates the blood or undergoes a chemical reaction that stimulates the natural blood clotting cascade. After application, hemostatic agent should be able to withstand the high pressure or flow of a bleeding wound. It should cause little or no damage to the tissue, and it should be easy to remove from the wound. not spread into the rest of the system as small particles. Wound packing. It works by absorbing liquid from the blood and helping to concentrate clotting factors. It involves taking standard initial steps to control the bleeding, including direct pressure, tourniquets, and other applicable tools and techniques. Pneumatic anti-shock garment, an inflatable device that covers the legs and abdomen. These devices are now rarely used. Always follow your local protocols. I've never used one of those. I'll tell you that right now. That's really rare if that is still even a thing.
So you're saying that I'm old since I've used them before?
Excuse me, we can take that back.
Shock trauma, they are phenomenal when they are needed and you're done. They do work really well, but they are old. They're starting to make their way back, but I think they're
I
going to
kind
stay
of
in the
wish
back
I'd
of the
been able to
closet.
use one. I wish I'd been able to use one just so that I could say I'd done it, but it's definitely one thing I cannot say that for. Anyway, hemorrhaging from the nose, ears, and the mouth. Several conditions can result in bleeding from the nose, ears, and or mouth. A skull fracture, facial injuries, including those caused by a direct blow to the nose, sinusitis, infections, nose drop use and abuse, dried or cracked nasal mucosa, high blood pressure, coagulation disorders, digital trauma from nose picking, epistaxis or nosebleed is a common emergency. And just so everybody knows, yes, somebody can go into cardiac arrest and lose enough blood from a nosebleed to go into cardiac arrest. It can happen. Take even those seriously. It can cause enough of blood loss to send the patient into shock. The blood you may see may only be a small part of the total blood loss. Much of the blood may pass down the throat into the stomach as the patient swallows. For a nosebleed from other conditions, apply cold compresses to the bridge of the nose while the patient leans forward. Do not have them lean back. As we all know, blood on the stomach, our blood and our stomach does not mix. An alternative is to roll gauze and place it under the patient's upper lip. Bleeding from the nose or ears following a head injury may indicate a skull fracture. If you suspect a skull fracture, loosely cover the bleeding site with a sterile gauze pad to collect the blood and help keep contaminants away from the site. Internal hemorrhaging, definitive care includes rapid transport to the ED. You can usually control internal bleeding into the extremities quite well in the field simply by splitting the extremity. Treatment focuses on the treatment of shock, minimizing movement of the injured or bleeding part of the region, and rapid transport. Ultrasonography may be used to locate the bleeding in the ED. Follow the steps in the skill drill 27.3 to care for patients with possible internal hemorrhage. A patient should be NPO, so give nothing by mouth. Insert at least 118 IV gauge catheter and administer fluid boluses of 250 milliliters of normal saline or lactated Ringer solution. Keep the patient warm. Monitor the serial vital signs and watch diligently for developing shock en route. The most important thing you can do for these patients is to keep that patient warm. Them losing their heat, it's going to be harder for them to bounce back from that trauma, and they're gonna have a harder time fighting all the fights that comes along with that. Your management of hemorrhagic shock, focus on exsanguinating hemorrhage first, your XABC. Identify and try to stop any major bleeding, and quickly evaluate the patient's hemodynamic status with a pulse check. Establish and maintain an open airway while maintaining manual stabilization if necessary. That being said, we've all talked about this in skill days. If you have a patient with potential cervical trauma, you're not going to use the head tilt chin lift to open the patient's airway if you need. You're going to go ahead and use that jaw thrust. So just keep that way, you can keep that C-spine mobilization and rock on. Route to the ED, insert at least one, preferably two 18 gauge peripheral IV lines. Obtain IV access at the scene only if the transport of the patient is delayed. Monitor the level of consciousness, the pulse, and the blood pressure. And I think that is at the end of our PowerPoint, guys. Lindsay, I'm seeing your video that you sent. That's cool. I'll have to save it and watch it in a little bit. Chris, do you have anything to add?
Sorry, no, I'm good. Guys, y'all please let us know if y'all have any questions, anything we can do to help you. She passed on some good information. I know Patricia's hanging out in the background. I got a text from her a while ago. If y'all have any questions for us, we're here to help. And if not, I'm gonna let Miss Bethany handle everything.
Awesome. I'm gonna stop recording, but y'all, I'll hang it back for about 4 or 5 minutes in case you guys need something, and